now. Um, yeah, welcome and thank you everyone for joining our Q&A webinar today. My name is Dr. Sofia Wenzler. I'm a licensed clinical psychologist and the clinical lead here at StopOCD. StopOCD is the program bringing this free webinar to you. It's a therapist-assisted online program to help you cope with compulsive behaviors and intrusive thoughts. And today we're going to go through some of the questions that we are most frequently asked here at StopOCD. Some of them are also very specific pre-submitted questions by you, but there's also going to be plenty of time and space at the end for you to ask each question that might come up. And you're very welcome to write those questions down in the Q&A section here on Zoom. Please don't raise your hand, just write the question down there. And even if you have follow-up questions, I usually get to those as well. All right, so let's jump right into it. I started for those questions that I have time to prepare before to even put them on slides, just so the question in itself stays present with you while I answer, or sometimes I use a graph to explain my train of thought. We're going to start with a really basic one. What exactly is OCD and how is it different from being perfectionistic or overly cautious? So I would say the first major difference is that being perfectionistic or overly cautious might be considered a personality trait that is just part of you, whereas OCD is a defined disorder. You can find it in the DSM and in the ICD. It has specific criteria. You're not born with it. It can sometimes feel like it's a part of you, but it actually isn't. It's a disorder that breaks out at some point in your life and then causes a certain amount of distress or impairs your daily functioning to a degree that we call it a disorder. When I explain what OCD is, I really like. Wait, I just see there's another question in the Q&A section. I just want to make sure that there's nobody complaining about me not being that my sound system is not working or something like that. Oh, okay. Well, that's a good question. Can I have a copy of a recorded video or recorded video of this free webinar? Yeah. So we record it because we're gonna put it online later on our YouTube channel. So you can find us StopOCD on YouTube. And so, like usually, a day after the webinar, you will find the recording there. You can rewatch it. You can send it to friends. So that's the whole purpose of us recording it. Okay, now I'm going to explain what OCD is in the way that I like to explain it, which is by looking at it as a cycle. Okay, almost every kind of OCD and every compulsion and intrusive thought you can put into a cycle to understand it better and also to understand where you can break the cycle. Now let's take the example of, for example, a person with magical thinking OCD. Let's say that person just stands at the side of the street and then he sees a child crossing the street. And then he might have an intrusive thought or a mental image of a car driving over the child, which is a very scary, image to hold in your head. That person might interpret that thought as I just imagined it, so it might actually come true, which of course will cause a lot of distress. And then if it's magical thinking OCD, they will probably engage in some kind of compulsion that might mentally overwrite this picture so it doesn't cause the event, or maybe you have to say a prayer or do some other seemingly not related act in order to make this event less likely from happening. So this is how the cycle of OCD usually works. I have an intrusive thought that I don't want. I interpret it in a way that causes distress, and then I reduce the distress with compulsive behavior, and that keeps the cycle going. Now, what is the OCD in this cycle? Because seeing a child crossing the street, that is not OCD, right? That trigger could happen to anyone. Also, and that's very important to understand, the intrusive thought is not necessarily what makes this OCD. Most people know what intrusive thoughts are. Most people know when you all of a sudden have a mental image that is scary or uncomfortable or funny in some way, or a thought where you think like, where did this thought come from? We all have it, right? The thing that's specific to OCD is the interpretation. The fact that people with OCD assign some kind of meaning to that thought in terms of like it might point towards reality or to me as a person, the distress that comes with this interpretation, and then the compulsive behavior that I can't stand in this state of distress, or that this distress is so intense that I have to do something about it. Um, and if you understand the cycle, you will also understand in more detail why OCD is, for example, not being perfectionistic or perfectionist. Perfectionist? I think I would say perfectionist. Because when you are a perfectionist, then the thoughts that make you kind of, for example, be very detail oriented about a presentation, or make you engage in those behaviors that could be described as perfectionist, will not seem unwanted to you. They will feel like they're coherent to who you are and to your values, right? So it's not what is this thought, where's this thought coming from? It will feel like your own thought that makes sense. And also, perfectionistic behaviors usually don't come from a place of distress, of trying a fear. It's oftentimes comes from a more of a place of shame or self-criticism than something bad happening. Um, why is OCD different from being overly cautious? It's not necessarily at all different, because I would describe a lot of people who suffer from OCD as overly cautious. I mean, OCD in and of itself is kind of having a hard time coping with uncertainty, or coping with the idea of causing some kind of damage or some kind of bad thing happening, which you could also compare to being overly cautious. Um, but it's much more than that. OCD can, while being overly cautious will probably be something related to, daily doubts or daily fears. Like, you can be overly cautious in traffic. You can be overly cautious about your performance at work. You can have OCD about just about anything. And sometimes OCD themes are also things that most people commonly don't worry about, right? Also, OCD causes much more distress, and impacts your life in a different way. And lastly, people who are overly cautious about certain things will, again, they will think like, that makes sense, I should be cautious. Whereas people with OCD oftentimes think like, no, my behavior makes no sense. This is exaggerated. This is too much. And that's why you try to break the cycle. Um, yeah. So now that we hopefully have a clear understanding of what OCD is, another question: can OCD symptoms change over time or evolve into new patterns? That is certainly a question that we get asked a lot here at StopOCD, because it is such a complicated disorder that can change its appearance and its features. You can cope with some kind of OCD, and then it gets better, and then it just finds its way back into your life through a different path. But at its core, it's always going to stay the same. So, yes, compulsions can change. It can start with behavioral compulsion and move to mental ones. You can kind of get a grip of some kind of compulsions, and then some others might pop up. Even the theme of your OCD can change. It can go from contamination OCD to harm OCD, or to sexual OCD. You can have several OCD themes at the same time. What usually doesn't change is two things: the basic idea of OCD, or the kind of structure of OCD, which I mean the cycle, right? The content of the cycle can change, but it's always going to be a cycle. And also, there's this idea that I find very, very useful, which is the core fear. Usually, every person with OCD has one core fear that lies at the very, very base of all of their compulsive behaviors and thoughts and OCD themes. And while other things can fluctuate, this core fear usually stays the same. And the core fear is kind of what lies at the end of all of your doubts, of all the what ifs that the OCD usually asks you. And I'm going to give you an example of that that I took from another webinar that I gave recently. Maybe some of you will recognize it. So let's say, like, getting to the core fear is like peeling an onion, in my head at least. Let's say a person has an intrusive thought of an image of them stabbing their girlfriend. Okay, I just had an intrusive image of me stabbing my girlfriend. If we go one layer deeper into it, if we ask this what if chain to the end, then the next step would be like, okay, if that's true, that means that maybe I actually mean to do that. Why else would I have the thought? If that is true, then there is a high likelihood I will actually stab her. If that is true, she will die in front of my eyes and I will go to jail. If that comes true, no one will ever visit me and everyone I know will think of me as a bad person. If that is your chain of reasoning, then it's very likely that your core fear would be rejection. At the end of all of those what ifs, at the core of all of like the many different compulsive behaviors or OCD themes you might suffer from, there's a deep, deep, very real fear of a very scary outcome that is rejection. Other core fears involve going crazy, being a bad or immoral person, contracting a fatal disease and suffering, dying, or going to hell when it's religious OCD. So I feel like, yeah, OCD can change its face and its shape all the time, but there's some core to it that will stay the same. And in my opinion, also, if you do ERP, if you effectively treat your OCD, then working on one theme or one compulsion will, the understanding and the progress that you make there will be transferable to others. Like, as long as you work on challenging this core fear and breaking the cycle again and again. Um, when should someone seek a formal diagnosis? The short answer to this question is always. Why would you not? Like, if you suspect that, yeah, you have OCD, go for it. If you if it's accessible to you to get a formal diagnosis, I would say there is very few reasons not to do it. If you suspect that you have OCD and you can't know for sure until you've talked to someone who really is a professional and really knows the disorder, because there are a lot of misconceptions about it, and it's not an easy thing to diagnose. Cases where I especially would advise seeking a professional diagnosis is if you feel like your thoughts are causing a lot of distress, if you feel like your compulsions are taking up a lot of space in your life or severely interfering with your level of functioning. And if you notice, okay, there's just this thing going on that I can't find my way out of on my own. And there's many benefits to getting a formal diagnosis. First of all, you have a name for what's going on and what you're experiencing. You're gonna get a better understanding of what's going on, and you have a definition for it. That will help you find the right treatment, because if you're misdiagnosed, you might, get the wrong treatment. Also, it's very validating. You're not exaggerating, you're not weird, you're not different from everyone else. You have a disorder that a lot of people share with you, and that's treatable. It, it will be easier to refer you to the right services. It might help get health insurance coverage. And finally, um, it might help you get the right support also at work or in your private life, when you know what's going on and when you have a name for it that other people can understand. How does cognitive behavioral therapy specifically treat OCD? Okay, that's another great question, because just that, like, a lot of people have heard the term OCD and have misconceptions about it, or don't know exact, or just a vague understanding. I feel the same is true for CBT. It's something that specifically, if you've been looking for treatment for OCD, you might have heard that term, but it's like, what is it exactly? How is it different from ERP? Why are all of those abbreviations? And why are the real terms so long and weird and hard to understand? So, um, first of all, let me kind of give you a short definition of what CBT is. So, cognitive behavioral therapy, right? Cognition stands for thoughts, behavioral stands for behavior, obviously. And CBT, at its very base, relies on the assumption that our emotions, thoughts, and behaviors are connected, and that through changing our behavior, or working on our thought patterns, we can affect the way we feel. Because the way we feel oftentimes is, what leads us to therapy. I'm depressed. Um, I have anger management issues. I have anxiety and fears that make me avoid certain situations. Um, but as you all know, saying, oh, like, don't be mad, or don't be afraid, or calm down, or cheer up, those things don't work. You can't directly affect your emotions, right? So the idea is that through changing other things in our lives, the way we look at things, the way we interpret things, the way we behave, we can make a change in the way we feel. That's one very important thing to know about CBT, in my opinion. The other thing is that CBT is evidence-based therapy. Whereas, for example, psychoanalysis, you might have heard the name Sigmund Freud. A lot of therapeutic approaches are based on the experience of very smart people, on personal theories about how the mind works, and very little research. That does not mean that those approaches aren't effective. That does not mean that today we haven't done research to test whether those therapeutic approaches actually help, but they're not based on research. Whereas CBT is an approach that wasn't invented by one person. It is based on many, many, many different research projects and understandings that we drew from that research, that were then combined. It started with the behavioral wave. You might have heard about Pavlov, who did this experiment where he presented dogs with food while they rang a bell, and then kind of established the idea of habituation, because later on, only hearing the bell would make the dog salivate, because in their head, in their brain, a connection was created between the bell and the food, right? And so this is one of the most basic research that laid the groundwork for CBT, for understanding how our behavior can be influenced, and how through behavior we can affect or internal processes. And then there was a second wave in the 70s and 80s, where we analyzed more how thinking patterns affect us and how we affect thinking patterns. And this is how CBT was born. Wow, that was a really long explanation. Today, we have many different ways how CBT can help for different disorders. There's kind of different adaptations of CBT for different problems, and all kinds of third wave CBT approaches that include also concepts such as mindfulness, or connect CBT to other approaches. And that leads us to ERP, which ERP is kind of the CBT adaptation for OCD. So ERP is a kind of CBT that was specifically developed for people with OCD. And it goes through the behavioral channel. So we try to reduce the distress in the long run through changing behavior, through reducing compulsions, in order to learn that we don't need the compulsions to stay safe, right? And then also in CBT, we would use the cognitive channel, try to influence our internal states through reinterpreting intrusive thoughts, trying to challenge how much meaning we want to give those thoughts, how much power we want to give those thoughts, again, in order to reduce the distress and the loss of functioning that OCD causes in our lives. That leads us to a pre-submitted question. Will ERP work when I came off my medication 5 months ago? My anxiety is high and my OCD is getting worse. I came off meds due to weight gain. Um, that is actually a very good and commonly asked question. First of all, I want to just normalize, like, a lot of people experience what the person who asked this question experiences, that SSRIs, medication for OCD, can cause weight gain. And sometimes because you take the medication in a really high dosage over a really long period of time, that weight gain can become a very big obstacle and a reason to stop taking the medication, because it's not easy to deal with those big changes in your body. And I have experienced that with many patients, and it's a really difficult thing to cope with when you're taking medication for OCD, and when this is one of your side effects. Now let's talk about how medication and ERP work together. So as I mentioned before, ERP, the way it works is we reduce compulsive behaviors, so we can learn several things that we are strong enough to deal with the distress. We don't need to engage in the compulsion. We can survive without it. That the distress will go down over time, and that the feared outcome doesn't come true. You know, I can touch the door handle, and that does not mean that I contracted a deadly virus, although the thought of contracting a deadly virus is super scary. So it really touches the core of the cycle. It breaks the cycle, touches the core of OCD, and makes, if you do it consistently, it can make a huge change for you. Medication works in a different way. Medication that we prescribe for OCD, I'm not a psychiatrist, by the way. I don't prescribe medication. I just know a little bit about it. Reduces anxiety and distress. So for people who have moderate to severe OCD, it might be very hard, the idea of doing ERP, the idea of not doing a compulsion, because the level of distress that they feel after having an intrusive thought is so high. And that's where medication can come in. If it reduces the level of distress to a certain degree, It might make ERP more possible. In and of itself, just taking the medication might help you a little bit with the symptoms, but it doesn't mean that you're healing your OCD or you're actively working on your OCD. It means that you reduce the distress that the OCD causes. Um, and so what is usually recommended is that for mild to moderate OCD, ERP might be enough. If that's not enough, or if you have moderate to severe OCD, or if you have comorbidities, or if for whatever reason you do not want to do ERP, then we would recommend medication as well. But the combination of medication and ERP, specifically for moderate to severe OCD, would be the gold standard idea. Coming back to the question that was asked, yes, ERP can be effective also without medication if you are able to do it without medication. If you're able to do the exposure exercises without the medication, then it should still be effective. Okay. I have OCD without physical compulsions, just mental. One of my issues is thoughts about having thoughts. My OCD voice says, think that thought, and now think of something worse. And this continues until sometimes I feel I'm going crazy. How would you describe this type of OCD, and can ERP help with this? So this is one pre-submitted question where I was actually happy to have a moment to think about it because it's a little bit complicated and I'm missing a little bit of information here. I don't really know what the content of the thoughts is. And I was thinking about it. I was thinking about two different ways how I can translate it to the psycho, which the psycho always helps to understand what the right treatment approach would be. So my hope is that the way I interpreted this question is correct. If the person who asked it will now understand that it's not correct, you please write in the Q&A section and clarify. And if the person who asked this will watch the recording later and my answer is not helpful, then please just write to our customer service and we'll go deeper into it. Anyway, so my interpretation of this question is that this person, caused by some trigger, will have the need to think of certain thought. Like the OCD says, think that thought. And for some reason, this is a thought that you should not be thinking. So the OCD tells you to think thoughts that you're not supposed to, that for whichever reason you think you're not supposed to think. That might be because those thoughts are morally questionable or have like a blasphemous or aggressive or sexual content. And that's why it's not okay to think those thoughts. This would then cause distress and possibly some mental compulsions of trying to push the thought away or trying to neutralize the thought. But then the OCD comes back in and says, now think something even worse. And then you go through the cycle until you think you're, going crazy in your head. That would make sense for me because, like, when people say most of their compulsions are mental, then a lot of times it is about it is about themes such as aggressive, sexual, or religious OCD. And I mean, if it was okay to think those thoughts, then why would it be a problem if it was just any random thought? In terms of what would I do with that? First of all, I wouldn't only do ERP, I would also do cognitive work. I find cognitive work very, very important. OCD makes us believe that our thoughts have meaning. And while some of your thoughts do have meaning, intrusive, unwanted thoughts don't. if at all, they show you what's dear and important to you, right? But our thoughts are not dangerous. You can think whatever thought you want to think, and that doesn't point towards anything happening, or that doesn't define your personality. The problem is the moment you try to push the thought away, it's like, don't think about the pink elephant. Then you get hyper focused on the thought, and it can lead you to a place where you think, like, I can't think about anything else. But like this understanding that you're allowed to think whatever thought doesn't mean that you're going to do something that's going to happen, that something's going to happen, or that you're a certain kind of person. So I think that understanding is very important. And then in terms of ERP, if the OCD makes you think that it's forbidden to think this thought, then the ERP would be to think that thought on purpose. Not only when it comes up naturally, but like take certain times in the day where you think this thought actively, where you try to, by yourself, think the next worst thought and see that you can have all of those thoughts and nothing bad will happen. You might also work on the way you shift your attention, right? I really like the work of Michael Greenberg when it comes to coping with mental compulsions and the way we assign attention to our intrusive thoughts. And I would try to work on paying as little attention to the intrusive thought as possible without actively pushing it away. Okay, those were my 2 cents about this question. Oh, yeah. Another very important question. Are there strategies to reduce compulsions without triggering anxiety spikes? Or sometimes people just ask, do I have to do exposures? Is there no way around the exposures because the exposure is what causes the anxiety and it's so hard to do? And sometimes, as a person who treats a lot of OCD, I do feel like a drill sergeant, or that I constantly convince people to do stuff that's like super hard and super scary to them. But the answer is usually to reduce compulsions, you will have to deal with anxiety. The whole point is, and you see that in the cycle, that you do the compulsion to reduce the distress, right? So if you don't do the compulsion, you're left with the distress. So if you learn to reduce the compulsions, which the compulsions are what, mess up your life, they take time out of your life, they make you avoid certain things. You want to reduce the compulsions, and if you do that, you're naturally going to have to face the distress that the compulsion was previously saving you from. So mostly my answer is yes. There are some very few cases where people might, just through understanding what OCD is, through questioning their intrusive thoughts, already be able to reduce compulsions without experiencing too much anxiety. But this is very rare, right? So in most cases, you have to face your fears. I mean, also in a lot of other disorders, that's what you have to do to make a real change in your life. Is it ever appropriate to tell someone with OCD to just stop thinking about it? Maybe we can rephrase that to, is it ever helpful to tell someone with OCD to just stop thinking about it? And the answer is no. I cannot imagine any scenario in which it is helpful to tell someone with OCD that might be helpful. To tell someone with OCD to just stop thinking about it, that's never helpful. There's a lot of situations in which it might be hurtful or cause damage, because If it was so easy to stop thinking about it, then a person with OCD might have come up with that idea by themselves, implying that they could just stop thinking about it. Implies that it's completely in their control, and that the fact that they still have OCD means like it's their fault, or that they're failing, or as if they chose to think about something they don't want to think about actively. So in many ways, it can be harmful or hurtful. In no way that I can imagine, at least, it can be helpful. And also, just even if you just imagine yourself worrying about something, and then someone says just stop thinking about it. Like, also with when you don't have OCD, that is not a helpful sentence. It's almost like saying don't think about the pink elephant in the room. It doesn't work. Hmm. How do I explain OCD to my partner, children, or employer? Um, that is such an important question. We actually, in the Stop OCD program, we have a whole session only on that topic. How do I talk to others about what I'm experiencing? Because there is so much misconception. Sometimes it does look weird from the outside. So that's a big one, and I'm just not going to be able to give all the information here, but just a few thoughts from my side. First of all, if that's what you're asking yourself, then that is amazing, and it's a very brave thing to consider. I personally think that sharing about your OCD is in and of itself already therapeutic. It's very difficult. You might be anxious about it, but basically, if you share with another person what you're telling yourself, your inner child, as you may look at it, is there's nothing to be ashamed about. There's nothing to hide away, right, about this. And that reduces shame for yourself and can feel very, very relieving and freeing. Um, and also, it can increase connection with other people. Sharing about your vulnerable parts always has a connective character, and it also can open up possibilities to get support. So there's a lot of reasons why you should do that. Um, what the conversation will look like can vary largely by like who you're talking to, who you are, how you feel about your OCD. So I can't give you general guidance on that. I feel like it's a very personal thing, but in my opinion, preparation is key. There are certain things that you should think about before sharing, so you feel prepared. So first of all, obviously choose wisely who you want to share that with. Should be someone either where it's like absolutely necessary that you have to share it with them, or people that you really trust and feel comfortable with. And then also, it's very important to decide before how much you want to share, right? There is different levels. You can share just the fact that you have OCD, or that it's certain kind of OCD, or you can go into more detail or describe how you feel about it. And it really is up to you what you feel comfortable with, but also up to the situation. I mean, like if it's your partner, you might want to be more open. If it's your boss, you might just want to disclose the situation. If it's your child, you might want to think about what kind of information is digestible to them or understandable to them. And then once you understand exactly what you want to share and where your boundaries are at, you will feel much more anchored while you have the conversation. I mean, the moment you have the conversation, especially if you're anxious about it, it's easy to get lost. But if you're very, very clear on your boundaries in advance, you will have an easier time also to say, like, this is not something I'm comfortable sharing, or this is enough for me for today, or um, understand when someone is crossing your boundary and then leave the situation. Um, the fourth advice I can give you is I call it like share casually. When you share about it, don't feel like you're disclosing this like huge secret, burdening someone else. Like it's supposed to be a big deal. My dream is that we start talking about psychological or mental health related struggles the way we talk about, for example, having a fever or having diabetes or having an allergy. Like it's just something that you're allowed to talk to and that you're not supposed to be ashamed of, or you're not supposed to um, think that you're expecting a lot from another person to be hearing about that. And then lastly, be conscious of your expectations. Think about what realistic expectations of this conversation are, what you can expect from the other person. What are the aspects of this conversation that are in your control? For example, how much you disclose or how you want to tell your story, and what is not in your control. For example, how well the other person will understand you, how validating they will react. Um, and just, go into the conversation with the right expectations. Mm, I'm looking at the time. Uh, let's go through to one more question. How can someone manage OCD in high stress situations? For example, work, school, or travel. Mm, that is also a wonderful question that I hear a lot, because what actually happens with people when people have OCD, or what happens a lot, is that we start avoiding situations that might be high stress or that we're afraid of. Um, Generally, people with OCD tend to have higher overall stress level just caused by the disorder. And then imagine, when your overall stress level is also higher, then dealing with, regular stressful events that we experience in our day-to-day life, like doing a presentation, having a difficult meeting with your boss, um, going through traffic, fighting with your partner, and things like that. So OCD can make those situations more challenging. It can, so first of all, your overall stress level, like the stress you might perceive in the situation might be higher than that of someone without OCD, because your overall stress level is already higher. You might be distracted by your intrusive thoughts, or compulsions might get in the way. You might have an talk to your boss, have an aggressive thought of um, stabbing them, not because of the conversation, but because of your OCD, and then have the need to leave the conversation or to sit on your hands, which will look weird, right? And then you're already distracted, and then you're like, what did we just talk about? And so, yeah, it can be difficult to navigate those kinds of situations when you have OCD. One thing that I tell my patients again and again, like a mantra, is you can do everything, even if you have OCD. Avoidance is not your friend. Avoidance will make the OCD worse. It might be harder to do it with OCD. It might feel like you're having an extra um, piece of luggage with you, an extra suitcase that you have to carry through the situation, but you can do everything with OCD as well. And if you do it repeatedly, it might also get easier. Intrusive thoughts are not dangerous. Um, they can't stop you from living your life. They can just make it a little bit more complicated sometimes. Um, if you feel like you're in a stressful situation and your OCD is getting in the way, then it, there are some strategies that can help. You can do some grounding, for example. For a moment, just try to, let's say you're in a meeting and you get overwhelmed, just for a moment, try to find five different colors in the room or listen to three different sounds in the room. You can try to take some deep breaths. You can try to reset your focus to the situation and away from your intrusive thoughts, almost like there's a really annoying radio station in the background, but what you're focusing on is what your boss is saying or what your partner is saying. But also, what helps is just a certain level of acceptance that OCD can make it harder, but again, that you can still do it. You can still do it all, right? OCD does not have to stop you from living your life. Okay. I think that's enough of me talking for today. Now would be the time for you, if you want to ask each and any question that might have come up um, while I was talking. I'm gonna check the Q&A section. And we have one question at this point. What medications are most effective for OCD? Um, there is, I think, five uh, different medications that are recommended by the FDA, officially recommended by the FDA for OCD. I'm very bad at naming all of them by heart because um, they all, except for one, come from the group of selective serotonin reuptake inhibitors, in short, SSRIs. But I always tend to get confused which SSRIs are specifically helpful for OCD and which ones are SSRIs that are prescribed for depression and anxiety. If you go to if you Google search FDA approved OCD medication, or if you go to the IOCDF, the International OCD Foundation, you can find a list of those medications. Basically, what they do is they increase the level of serotonin in your system. The same medications are given in a certain dosage for depression and anxiety. And then for OCD, we don't know exactly why that is true, but we know that it is true. You need a higher dosage. So whereas for depression, usually you give those SSRIs at a lower dosage, and they will reach a certain effect within usually like about 2 weeks. For OCD, it's a little bit more complicated. It can take up to 3 months. And then you also have to up the dosage more and get to higher levels usually for it to be effective. That being said, it can be a really, really good um, addition to ERP practice. It just also sometimes is difficult because it takes longer. And as we saw in this one question that was submitted, also sometimes you deal with side effects such as weight gain. Yeah. Are there any other questions? This would be the time. Okay. Well, if there aren't any other questions at this point, I want to thank all of you for attending, for taking the time. Um, I hope I'll see you around for the next webinar. If any questions come up in the meantime, I'm really happy for those pre-submitted ones because then I can really take some time to think about my answers. And I hope you have a wonderful rest of your day wherever you are in the world. Thank you.